Good day, my name is Dr. Caterina Leiretana. I'd like to thank PCP for the opportunity to speak with you today, along with Dr. Alora. I will be discussing the perspective from policy for ethical dilemmas in HIV. I don't have any potential conflict of interest to declare. For the next 10 minutes, I will endeavor the following objectives: to explain concepts related to ethical issues in HIV discussed in the case, to identify statements in current national policy that support such concepts, and to share existing health benefits for people living with HIV. These are the national policies that I used as references for today's topic. I have identified four statements in the case that may present dilemmas and their corresponding concepts. We will be discussing the concepts of compulsory testing, disclosure, and health access. Our first issue: patient initially refuses testing. To know what we can do about the situation, we need to know what we can't do. Can we, as healthcare providers, actually require HIV testing since it will be beneficial to them after all? The short answer is no. HIV testing is not compulsory. So, compulsory testing refers to testing imposed upon an individual characterized by lack of consent, use of force or intimidation, use of testing as a prerequisite for employment, and other circumstances wherein informed choice or consent is absent. The Republic Act 11166, or the HIV law, clearly states that unless otherwise specified, the confidentiality and non-compulsory nature of HIV testing and HIV-related testing shall always be guaranteed and protected by the state. No testing shall be conducted without informed consent. Well, the good thing is our patient eventually relented. But how should we approach a patient that refuses testing? First, let's see what went wrong in our initial approach. Was the environment not suitable for pre-test counseling? Note that the approach varies per patient. Someone who is admitted with PCP may have a different mindset from someone who walks in an outpatient HIV testing center. So first, let's create a private and respectful environment. Most people will not be comfortable talking about sex and HIV with other people around. Then, explain the rationale and benefits of testing, which in this case is honestly documentation at this point. Patients can actually be treated for opportunistic infections like PCP while at the hospital, even without doing the HIV test while admitted. In several instances, the HIV test may be done after discharge by the patient himself in an outpatient setting. You can ask help from a counselor. Sometimes having someone outside of the healthcare team works better. Find a relatable peer who is trained in counseling, one he can confide in. And of course, acknowledge that patients have the right to refuse testing because sometimes psychosocial consequences and a low risk perception can weigh more than the compelling benefits of an HIV test result. But even in the face of failure, please always encourage an HIV test. And this is where we as healthcare providers can hone our skills more. Provider initiated counseling and testing, or PICT, is our duty. We should be able to encourage an HIV test with patients whom we deem to be at risk for HIV, no matter what their initial complaint might be. PICT must be accessible to all and should be part of clinical care, no matter what your area of practice is. You don't need to be a seasoned counselor to inspire your patients to know their HIV status. Our second issue in this case involves the concept of disclosure. The patient refuses to inform his partner despite knowing the risk of transmission. So, partner notification or disclosure refers to the process by which your index client with HIV is given support by the healthcare institution so he can notify and advise the partners exposed. So, support includes giving him a mechanism to encourage the client's partner to attend counseling, testing, and other prevention and treatment services. Of course, confidentiality is observed throughout. The law states that any person after having been tested, found to have HIV is strongly encouraged to disclose his health condition to his partner, especially prior to engaging in penetrative sex or any potential exposure to HIV. So the patient is not required nor obliged to disclose. However, as healthcare providers, we can highly recommend this practice along with education regarding transmission, instruction regarding safer sex, and impressing the value of disclosure to sex partners. We should remember also, we should take into consideration the consequences of disclosing given the social stigma that surrounds HIV. For sex between two consenting adults, in the past it becomes less of a legal and more of a moral issue. And for partners in the future, disclosure becomes less relevant medically, as the risk of HIV transmission through condomless sex when HIV viral load is suppressed from effective treatment is effectively zero. This undetectable equals untransmittable or U equals U campaign has removed the burden of guilt among people living with HIV and has done wonders for their self-esteem. So the next issue in our case includes two concepts. Keeping accurate records as a good medical practice and lack of health access. So as healthcare professionals, we have a duty to keep accurate medical records. So they include relevant clinical findings and the decisions we made and actions agreed upon by the health team. They should be complete, accurate, and fit for its purpose. Because information is not safe if it is not accurate, and it's our responsibility to ensure this. So what is recorded in patient records is not for the patient to dictate nor determine. We have professional and ethical responsibilities to record relevant information fully and accurately, not only for the benefit of the patient, but also as documentation that we gave proper care. But history has shown that doing this good clinical practice can actually cause loss of health access of patients dependent on HMO. So the new HIV law sought to change that. By definition, HMOs refer to judicial entities legally organized to provide or arrange healthcare to its enrolled members for a fixed prepaid fee for a specific period of time. So for a time, HMOs did not cover diseases related to STDs, HIV included. The Republic Act 11166 states that no PLHIV shall be denied or deprived of private health insurance coverage under HMO and private life insurance under a life insurance company on the basis of the person's HIV status. No person shall be denied of his life insurance claims if he dies of HIV or AIDS under a valid and subsisting life insurance policy. The exclusion from health, accident, or life insurance is prohibited, provided that the PLHIV has not concealed or misrepresented the fact to the insurance company upon application. So as mandated by law, the Insurance Commission developed its underwriting to guide HMOs. Unfortunately, this circular was met with protests from the Positive Network. So here we have on the right the position paper of Network Plus, which makes comments on some of the statements of the circular. So if we see the underlined portions, there are some inconsistencies with the existing law. So it says, an HMO may require applicants to undergo HIV testing. However, it should be voluntary. So that's an inconsistency right there. An HMO may suspend the acceptance of newly discovered HIV positive individuals. So that is against the statement of the law that no exclusions should be had. And then there are criterias for granting HMO coverage, which is again disputed by the Network Plus. So unfortunately, HMOs aren't consistent with their coverage despite the law. And with this underwriting still up in the air, the discussion is still ongoing. We have yet to see a consistent response among our HMO providers. This was one brave company's statement regarding HIV coverage after the HIV law was signed. um, Patients who are under HMOs that cover HIV, like this company, and who disclose their HMOs to their HMOs rather, benefit from it depending on their premium. Patients who have chosen to withhold their status prior to enactment of the law can still benefit from their HMO with recent disclosure as the law repeals decrees, EOs, proclamations, and AOs inconsistent with the provisions of the current law. So, what to advise our patient who requests not to tell the HMO? We should say that we as healthcare providers should write the correct diagnosis, which is pneumocystis jirovecii pneumonia, and assure them that HMO coverage is mandated by the current law. So aside from HMOs, what other benefits can our patients enjoy? So these are the mandates of the law for PhilHealth, but not all have actual packages. We have one that has been in existence though since 2013, and this is the OHAT, or the Outpatient HIV and AIDS Treatment Package. This benefits PLHIVs who are on ARTs. They are eligible to receive 7,500 a quarter or 30,000 a year if they file completely. 80% will go to HIV service delivery, and 20% will go to their healthcare team. So this is the current benefit enjoyed by people living with HIVs in the Philippines. So a diagnosis of HIV carries with it physical, mental, spiritual, and psychosocial baggage. I don't think there's any other disease laden with such a stigma enough to cripple a person's rational decision making. So the question, how often do we support PLHIVs psychosocially? We should do it throughout their journey. This is the HIV care cascade. It shows significant drops in patient retention at each level, and the greatest fallout comes after getting tested, receiving a positive result, and enrollment into care. Once we have them in care, we know that medications can result in viral suppression, as seen here in the 2016 DOH data. It shows that 92%, the last bar, of patients on effective ARTs achieve an undetectable state. So, if we give psychosocial support at all times, at all aspects of this HIV care cascade, we can expect retention. And retention is key to keeping an undetectable HIV population. It helps keep them healthy, helps them achieve a good quality of life, and helps also in HIV prevention because undetectable is untransmittable. So with that, I end this talk with a table of the policies I referenced throughout. We have Republic Act 11166, the HIV law, Republic Act 10173, the Data Privacy Act of 2012, the PhilHealth OHAT Circular, and the Insurance Commission Circular for the underwriting for HIV. Thank you for your time and good day.